In this video, we're going to look at the second cause of chronic pelvic pain, that associated with the insertion of vaginal mesh to cure urinary stress incontinence, which has caused a great deal of inconvenience to a large number of women around the world. Some years after the tape was inserted, it causes pain, sometimes causes direct damage to the urethra or the bladder, with continuous urinary leakage from the ensuing fistula, which is an abnormal communication from two epithelial surfaces. It's a very serious matter and causing a great deal of distress at the moment, but I don't think its etiology has been clearly described. So today what I'm going to do is spend 10 minutes just going through the anatomy of the situation and see if we can make some sense of it. This is a normal pelvis on the right, and this is what happens when you have urinary stress incontinence. So when you cough, normally everything is held up in the right place and there's no urinary leakage. However, after having had a baby, what happens is you have injuries, various injuries to the muscles, ligaments, and joints in the pelvis, which make and enable the bladder to be displaced downwards with urinary leakage, which is concurrent with a cough. We distinguish that very specifically from other forms of urinary incontinence. Now, if we look at this in real life using an MRI scan, on the left you can see the pubis at the front. This is the bone, then the urethra, vagina, and rectum, all nice and tightly ensheathed by the pelvic floor, which is this muscle here. And this muscle here attaches to another muscle on the pelvic sidewall, which will be significant in another video that we do shortly. And on this side, we have a woman with advanced stress incontinence. Here's the urethra. This is what's left of the vagina. It's not that nice butterfly conformation as on the left. And here, the pelvic floor is completely gone. It's lost its nerve supply. It's become denervated, very thin. And when the woman squeezes, she can't interrupt her flow of urine. Now, what a mesh procedure does, and we're illustrating two here. On the left, we're going to do what's called a transvaginal tape. On the right over here is a transvaginal tape passed through the obturator foramen, this hole in the bone here. Normally in a transvaginal tape, what you're trying to do is restore the support of the anterior vaginal wall, which is this nice shape here. And what you do is you pass it from the vagina up to the abdominal wall, and again on the second pass you put it up to the anterior abdominal wall, and you create a sling underneath the urethra against which the urethra can be compressed, and so the woman doesn't leak urine. Same idea with a TVT passed through the obturator shelf. It's called a TVTO. That one comes out in a different way, and it's slightly less morbidity apparently associated with this. A lot depends on the skill of the surgeon, but it's not a difficult procedure. What is difficult is leaving the sling loose, because you have to appreciate that the anatomy is disturbed in the incontinent woman, and that when she coughs or sneezes, the bladder neck is displaced downwards. What you want to do is put a mesh in there to stop that downward displacement, but you don't want to put it too tightly in, because that will cause difficulties which will get worse over time if the mesh becomes part of the body and contracts as it does in some circumstances. These are typical mesh results over the past 5 years. Very, very popular procedure, so thousands of articles, very few randomized trials, but generally accepted that you're going to get these sorts of rates of cure, which are not necessarily as good as the old-fashioned procedure, which was called a Colpo suspension, and then you get a little bit of vagueness about the complication rates and when they start, but there were no differences in these particular studies between the two different types of procedure. When you do get the complication, it's very serious indeed, and part of it arises from injuries to your autonomic nerves. Now, medicine's not very good at autonomic nerves because we lost them. We lost the full morphology in the post-war years. And here on the left, in this brown specimen, you can see this is the bone that you sit on, the sacrum. It's the pubis, uterus, cervix, vagina, rectum, and bladder. And on the right, in the yellow specimen, you see a representation of all the nerves, which are these brown structures here, at numbers 33, 32, and 8. In fact, what formalin does is it destroys the autonomic nerves in the specimens. So many generations of doctors haven't seen the full morphology, and they're out of sight and out of mind. But when you start looking at these tissues with respect to the nerves, you get some surprises. When you cut a nerve, this is a normal nerve at the top, this is a normal nerve bundle here. When you cut a nerve, say here, what happens is you get all this sprouting of nerve bundles from the proximal stump, and they grow back in a very different and chaotic fashion. They express a wide range of new stretch receptors and pain receptors, and they are entirely abnormal. It's called collateral sprouting of a nerve bundle. When you touch these things, they're intensely painful, intensely painful. They're caused by things such as straining on the loo, difficult first labors, and gynecological surgery. What you see in a mesh patient, a vaginal wall in a mesh patient, is this sort of collateral sprouting, but also where the nerves grow round these small blood vessels. So here, all these brown abnormal nerves, here, and here, all growing around nerve, small arterioles, small blood vessels in the anterior vaginal wall. And when you see this, that's often associated with a longitudinal injury to the nerve bundle caused by straining on the toilet. And 20 to 30% of women will have difficulties with straining on the toilet. If you strain with a fixed mesh in place, that mesh tends to tear through the tissues of the anterior vaginal wall, such that it will not only cut through nerve bundles, but it will cut through the bladder and the urethra itself, causing this terrible complication of fistulation. So you have this terrible mess with terrible pain, combined with the leakage of urine, involuntary leakage of urine. It's a very difficult matter to put straight. And once you have it, once you have this pain, it's very, very difficult to manage. What we've found is that 50 to 60% in women, any women with pelvic floor problems, have this sort of difficulty. And this is an involuntary sort of problem. It's not constipation that you can easily correct with your diet, but you're going to try and do that. It's a very difficult and persistent refractory sort of constipation, which is the consequence of 2 children, a hysterectomy, and often going through the menopause before the poor woman presents with stress incontinence. These matters are being investigated in great detail by Baroness Cumberledge's review group, and she'll be reporting in July, we think the latest date for the report is. And she was going to give us the benefits of her thoughts on whether to persist with mesh procedures, which doesn't seem to be a viable option if this sort of constipation is involuntary and difficult to avoid. And clearly, any decision will require very careful thought about what's going to happen with these women with incontinence. There are alternative procedures such as copper suspension, and it can be done through a keyhole maneuver as well. So it's not that it's not impossible to correct these matters by other means, but you don't want an artificial piece of material inside you which is going to cause you this degree of trauma and distress for the rest of your life. So we think important to avoid mesh if at all possible. We'll see what the Baroness thinks.